of the coaching on board.
So are we set in current settings? Maybe, yeah. Yeah. Yeah, just 1 second. Okay, can I chat?
Yeah.
Ah, okay. Yeah. Is this microphone here?
Yeah, and also on the ceiling. That's fine. You can
I can
stand here or just move around.
Okay.
It's just... She might actually, because she's on the phone only, she might not be able to see this. But
Okay, you just texted me. She's on the call now and can hear us. I'll look. And it's not working yet.
Oh.
Right. Are you ready? I'm good. Okay. Wow.
You're ready for the last
So welcome everyone. I'm standing in for Murray today, introducing our speaker, who's Dr. Marian Wettstein, originally from Zürich, where he did his training, who's now a research fellow in the Department of Surgical Oncology at UHN, and also a master's student in IHPME, doing a degree in clinical epidemiology. And today he's hoping to transfer from the master's program to the PhD program. So this is officially a transfer oral defense, which means that there will be a 20-minute presentation, after which we'll have questions from originally, first of all, the external examiner, then the committee, other IHPME people, and then everybody else in the room. And we'll try to leave maybe 15 minutes at the end to discuss the defense, during which we'll ask everyone who's not IHPME faculty or on the committee to leave the room. So with no further ado, I'll ask Dr. Wettstein to begin.
Hello everyone, and thank you very much for giving me the opportunity to present my PhD thesis proposal. I'd like to talk about utilization of re-resection in T1 bladder cancer and the impact on oncological outcomes. So we can start with some background information on bladder cancer. It's the 5th most common cancer in Canada, and we generally distinguish 3 stages. We have a superficial stage that includes TIS tumors, TA, and T1 tumors. T1 tumors, the one I focus proposed thesis. And these tumors are confined to the mucosa of the bladder. And we generally treat these patients with endoscopic resection. Then we have invasive stage that includes T2, T3, and T4 tumors. And these tumors, they already invade the actual muscle of the bladder. And we offer these patients normally radical cystectomy, the surgical removal of the bladder, followed by reconstruction of the urinary tract. And last, we have metastatic stage, the first-line approach with platinum-based chemotherapy. So what's special about T1 bladder cancer? As I said, it's the one that goes, it's a superficial bladder cancer, and it goes down into submucosal tissue, but does not reach the bladder muscle yet. The recurrence rates are up to 60% high, and the progression rates to muscle-invasive disease are as high as 30%. And interestingly, patients that directly progress from T1 to T1, the muscle-invasive stage, they have a worse disease-specific survival than patients that present with primary T2 tumors. And furthermore, these T1 bladder cancer patients are often understaged due to incomplete or insufficient resections. So what's re-resection? We call it also repeat resection, or repeat TURBT, where this stands for transurethral resection of the bladder tumor. And we define it as a second TURBT within 2 to 6 weeks after the primary resection. And there are several proposed benefits of this intervention. First one is diagnostic. We get a more thorough analysis regarding potential muscle invasion, and this might lead to a change of our management plan to radical cystectomy. We have also prognostic benefits. We get additional information, and we can tailor the follow-up schedule of the patient and can also perform better counseling regarding recurrence and progression rates. And last, we have a therapeutic benefit. So all this re-resection leads to clearing of residual tumor, and this leads to an improved response to intravesical therapy. So all these T1 patients, they normally get adjuvant intravesical therapy with BCG, the attenuated tuberculosis bacterium, and has been shown that a re-resection improves the response rate. So re-resection got incorporated into the guidelines in 2007 in the American guidelines and in 2008 in the European guidelines. And the problem is, we know that from anecdotal data that implementation rates are quite poor, and we also know it from harder evidence. Non-Canadian jurisdiction studies showed implementation rates of 26 to 28%, and the study from Alberta that was population-based showed an increase from 27 to 38% in a range from 2007 to 2011. The evidence we have for this intervention of re-resection comes mostly from observational data. We have small to intermediate cohort size. There's one low-quality RCT, but we call it low quality since it was analyzed on a per protocol analysis. One might ask now, why do we need further observational research? First, it's important that we capture the implementation and the uptake of this intervention so we can improve the knowledge translation strategy. Second, it's important for us that we identify the patients that are at risk not receiving re-resection. This way we can isolate patients that do not get the treatment that they actually should get according to the guidelines. And last, it's important to determine the oncological benefit of this intervention. It's obvious we probably finally need an RCT, but it's highly challenging to perform an RCT in such a setting. And even if we can launch one, we have to wait for at least 10 years to get reliable results. So with an observational design, we can get earlier results to guide our practice. So the objectives of this PhD thesis are first to determine the rate of re-resection, primary T1 bladder cancer in the province of Ontario. Second, to identify the predictors of re-resection. And last, to determine the oncological benefit of re-resection. The study design is population-based, Ontario-wide, retrospective study using secondary data that are derived from the Institute of Clinical Evaluative Sciences, and they are also housed at Cancer Care Ontario. So this is the data flow that we have. The Cancer Care Ontario started to collect PDFs of or the bladder cancer pathology reports in 2001 on a population-wide base, and all these PDFs from the interval 2001 to 2015 were transferred to UHN, and we are currently abstracting all these pathology reports. And we will, at a later stage, link this data to the database housed at ISIS, and this will help us to create our initial cohort. We will use these reports that we got from Cancer Care Ontario to identify the primary incident cases of T1 bladder cancer between 2001 and 2015. And we will use the other databases housed at ISIS to cut our cohort and to exclude patients that got a diagnosis of bladder cancer before 2001. So we have the true incident cases of T1 bladder cancer. One might ask now, how good is the coverage of CCO regarding all these pathology reports? I will try to verify this coverage by comparing the number of PDFs we have to the number of total procedure in Ontario that can yield bladder cancer pathology reports. So that will have an impression how well this is covered by CCO. This is a scheme of the cohort. I'll start to accrue patients in January 2001 to December 2015. I will look back as early as possible to exclude any cancer diagnosis, bladder cancer diagnosis before January 2001, and I will be able to look into the future until December 2016 for oncological outcomes. I expect 4,320 patients. This is based on accrual window of 15 years, 1,800 bladder cancer cases per year in Ontario, a 20% fraction of T1 bladder cancer cases, and 20% of missingness. And maximum follow-up will be as long as 16 years. This is a visualization of the research procedure. We'll distinguish a group of patients who got re-resection from a group that didn't get re-resection. Re-resection can be defined quite simply as a second TURBT within 2 to 6 weeks after primary diagnosis, and this can be captured by OHIP. I will use additional definitions on a time horizon of 2 to 8 weeks and 2 to 10 weeks, since we might have waiting times that can confound this specification. And there's also a possibility that patients cannot come to a decision if they want to get re-resection or not. This will be used for later sensitivity analysis. And the last thing is to capture the intention of the TURBT, of the re-resection, since actually re-resection should be purely guideline driven. No matter what you have in your pathology report, if you have a T1, you should do re-resection. But there are definitely surgeons out there that don't do re-resection if they have a complete resection and if they sampled enough bladder muscle. So I will condition an additional definition on complete resection and sufficiently sampled muscularis propria to distinguish a guideline-driven re-resection versus re-resection that was driven by a complete resection or insufficient sampled muscularis, the bladder. Let's talk about objective 1. It's about the rate of re-resection in primary T1 bladder cancer. I will address this by interrupted time series analysis. Indexing will be done at the date of the primary resection, and the interruption point is the date between the American and the European meeting. So this will be between spring 2007 and spring 2008. And I will aggregate the data in quarters, and I expect to have about 30 data points before the publication of the new guidelines, before the interruption point, and 30 data points afterwards. And I expect, based on the sample size, to have about 72 observations per time unit and somewhat between 7 to 36 re-resection events all over the time period I'll look at. These are just some simulated rates for visualization purposes. We have here the pre-intervention area with a black color and the blue color with the post-intervention area. And I hope to see something like this, that we see an increase of the re-resection rates after the publication of the new guideline. From a statistical perspective, I'll address it with autoregressive integrated moving average modeling. And I plan to use a ramp function, since I assume that this intervention was kind of multiplicative distributed along the urologic community. So there were some people that were on the meetings, they came back to our institution, talked to their peers, the peers talked to their trainees. And so it will probably have a multiplicative effect. I think this will best be addressed with a ramp function. I will also perform additional analysis for sensitivity analysis regarding this alternative definitions of re-resection that I mentioned before. And I will also look into different subgroups of surgeon characteristics if we see a different behavior within surgeons that are in academic institution versus in a community practice setting. And I will also compare fellowship trained surgeons to non-fellowship trained surgeons. Let's talk now about objective 2, the independent predictors of re-resection. I will address this by logistic regression analysis. The outcome is evident, it's re-resection, yes versus no. I will include numerous patient level and surgeon level predictors. Model selection will be based on a screening approach, and I'll include candidate predictors that are significant at a p-value threshold of 0.25 into the full model. All these patients, they will be clustered at the surgeon level. So I assume to have between 100 and 200 surgeons in Ontario, and all these patients are clustered at their practices. I will account for that by using generalized estimating equations to get a more robust standard error. Furthermore, sensitivity analysis will be performed regarding alternative definitions of re-resection. Here's just a short overview of some of the most pertinent patient-level and surgeon-level predictors. We'll look at age, gender, tumor characteristics, comorbidities, socioeconomic status, relative. And regarding the surgeon-level predictors, have a look at age, gender of the surgeon, academic and community practice, caseload, years of practice, and fellowship training, yes versus no. The good thing regarding our sample size is we have the risk of overfitting the model is really low. I will have more than 4,000 patients, and the event rate will be throughout the observation period will be higher than 10%. So I will be able to fit a lot of predictors to the model. Let's go now to objective 3, the oncological benefit of re-resection. This is actual causal interference on the treatment effect of re-resection. The outcome will be time to bladder cancer specific death, and the predictor or the treatment is re-resection. To have two comparable cohorts to compare and to estimate the average treatment effect of re-resection, I will use a propensity score matching that's based on the predictors identified in objective 2, and also do a hard match on the most pertinent predictors. I really hope that I can get some two balanced groups, but if I'm not able to balance out the surgeon level covariates, I'll probably go for a preferential within cluster matching to try first to match all treatment units to control units within the cluster of the surgeon. And if it's not feasible to do this within a reasonable caliper wide, I'll do it, and it will be matched to a control unit outside of the surgeon cluster. Furthermore, I'll use a trace outcome. I plan to use cataract surgery to identify to further analyze the balance between the two matched groups. On the matched data set, I'll perform a Cox proportional hazards regression that accounts for competing risks. It accounts for matched nature of the data set, and I will adjust for remaining imbalances that persist after the matching process. And I will use an absolute standardized difference of the mean larger than 0.1 as a cutoff. And last, sensitivity and subgroup analysis will be performed according to the alternative definitions of re-resection. So, and last, subgroups based on patient and surgeon characteristics will be separately evaluated. I'd like to conclude. T1 bladder cancer is a dangerous neoplasia, and re-resection should be performed in all patients according to the current guidelines we have. We have an unclear implementation of this intervention, and the oncological benefit is not finally defined yet. This proposed study is able to provide a comprehensive and high-powered evaluation of re-resection in T1 bladder cancer at the population level. And the good thing about it is it can examine both the implementation and the oncological benefit of the intervention in one design. I think that this proposal is feasible. Data abstraction of the pathology reports that we have at UHN is already completed at 80%, with only 20 more % to go. I have secured funding for a timeline up to 4 years, and I have experienced a thesis committee in my back, ranging from methodological competent experts. Yeah, I'm looking forward to this project. I'm looking forward to your questions, and thank you for your attention.
So do you want to start?
Sure. Thank you for the presentation and for involving me. Nice presentation, nice topic. A couple of things. Number one, how did you settle on the re-resection timeline of 2 to 6 weeks? Speaking in our somewhat third world-ish Canadian environment as opposed to, Switzerland, not all of our patients can get in for re-resection in 6 weeks. I know you're doing a sensitivity analysis, but Zürich, maybe you can do it faster than me, but trying to get people in 6 weeks when it takes just 2 to 3 to get the pathology results seems a bit ambitious. And maybe you should set your definition longer. Do you have any thoughts about that?
Yeah, we talked. I thought about this, and if we make it too long, I'm afraid that I'll include that I will include treatment decisions that are defined on the cystoscopic results. Since the patients are all scoped in for 3 months afterwards, I hope if I make it too long that the actual benefit of re-resection will be confounded by the first follow-up cystoscopy. That's what I was afraid of.
And so then, I think in your outline you talked about excluding a number of cases. So, for example, if you have a cystectomy within X period of time of your initial TURBT, presumably those patients they'll be excluded from the study because they're going straight to cystectomy. What if you've got multiple pathologies? So, if you have one T1 tumor and a T2 tumor in the same, but at the same time, same TURBT, are you going to exclude those patients as well, since something else may be driving their treatment?
So the re-resection was has T2 tumor or the initial resection?
Initial resection. So if the initial resection has two tumors, one of them's a T1 and another one's a T2,
then we're able to exclude it. Since the good thing is we really abstract this data on our own. So we have all the pathology reports of these patients and can.
And how are you doing the look back? So you have a look back window prior to 2001 to exclude, to try and confirm that there are incident urothelial carcinoma cases. There was no PDF capture from CCO prior to 2001, so correct me if I'm wrong. So then how are you verifying these are incident?
I will use the ClinEpi. Then on and back to the earliest news also for publication of the ClinEpi data in the early 90s. So I will look there for bladder cancer tumors. But you're right, I will not be able to get the definitive histology of this patient.
So you're going to look back for TURBT billing codes.
This will be really good input, so this might even more enhance the homogeneity of the cohort. So will we pay bladder cancer in a diagnosis and also be TURBT codes?
Yeah, because I think looking at you could look further back for TURBT codes to exclude ones who have those prior to your 2001 threshold, because I'm not sure that the ClinEpi, how accurate those diagnostic codes are, especially since some of these TURBTs may be done on an outpatient basis, although maybe before 2001, not that many of them were.
No, OCR will have it. It's not available as PDFs, it's available in some other format. So, like, for example, when I did my thesis, I had reports from different pathologists around the province in '94. So it's just not readily available in this ICD-10 era, but that should be available through OCR.
And then, so time trend analyses are complicated. I'm no expert in time trend analyses. Happily, there are some out there. Who's your main time trend analysis guru?
Mohammed Mamdani.
Okay. All right. I know Mohammed does it, but he doesn't like do it all the time. Mainly, like, I'm not questioning Mohammed, but I know I sat on a thesis committee where, you know, he gave input, but in terms of like actually creating the models and doing the stats and that kind of thing, it's you may need somebody local at ICE.
You have link with your committee.
Okay, that's fine.
Yeah, so
and so when you, a little bit more about that, how are you going to initialize your ARIMA model? Are you going to use back forecasting? Do you have any more detail on how you plan on doing that?
I can go back to. I plan to fit a model to the pre-intervention timeline, and then I'll get the prediction with 95% intervals, and I will look how the new data points behave relating to this prediction. I think it will be really shown when I have the final data. Maybe in best case, I'm even able to look at monthly intervals. So I would just want to be a little bit more conservative and look into intervals of the quarters.
You're doing quarterly. Okay, great. And how detailed will your patient factors be for your sensitivity analysis? For example, like what are some of the patient factors you're looking at? Are you looking at tumor size, grade, those kinds of things? What kind of detail?
That's really the strength of design. Since we have pathology reports, we have much more data that are available at ICE currently. So we have even some adverse pathological variables that are all in this pathology reports. So.
And then, sorry, final one. The most novel part of your study, I think, is the potential impact on mortality or your predictors of mortality. So you had sample size calculations previously, or guesstimating you're going to have 4,120 patients, or in a certain number of events. What kind of power are you predicting for mortality differences? What do you expect is the mortality in this group, and what are your expected differences in the T1 non-resected versus T1 resected, re-resected? I mean,
good question. Can I answer this finally? And I couldn't do a reasonable power analysis so far. I'm still struggling with this since we have the propensity match setting, and on the top of the propensity match setting, we have the accounting for the different clusters, and this made the calculation too complicated so far, so we have to do this definitely.
So what's the event rate? Like, what do you think your event rate of death will be?
At which time frame?
Well, it's any time frame, isn't it? I mean, so you're looking at the period of time is 2001 to 15, so 14 years.
Mm-hmm.
How many deaths from urothelial carcinoma T1 do you expect in that time period? You got 4,100 to start with, or all told.
So that's a good question. If it's really accounting for competing risk, I would probably assume at the time we have up to more than 10 years, more than I think 20 to 30% will finally die of really bladder cancer related issue. So we're such a high age group. Yeah, because so many competing risks.
So that should allow you at least to do a back of the envelope calculation of how many events you may have, and then what ability you have to detect a difference in them between the 2 years. But that's great. Yeah, thank you.
Thank you.
Questions from anybody else? Really? Who's saying?
Okay.
It's okay.
Can I see the third one?
Objective 3.
The outcome.
Which one? Here?
The outcome. The outcome definition is time to
Bladder cancer specific.
death, and then so are you using competing risk or not?
I will use this in the final modeling on the mesh.
I think Cox is dealing with the competing risk.
Or?
I don't think Cox can be useful in competing risk, which means you have bladder cancer specific mortality and all-cause mortality, right?
Will be a competing risk regression.
Okay. But I'll tell you something else. So we have a similar study. We have all on the patients who had prostate cancer. We got it from OCR, and then we wanted to look at the prostate cancer specific mortality, and then realized there is no consensus how you approach to it. So because that certificates are not accurate. So if you just use the diagnostic code for bladder cancer, for example, in your case, the issue with coding is because patients who died from metastatic diseases, sometimes they are coded as death from that specific metastatic cancer versus the other one. So we are right now kind of preparing a paper to talk about it. I mean, if you are doing, maybe you can also do sensitivity analysis looking at just your outcome is bladder cancer specific mortality, and then you can say bladder cancer plus patients who died from other cancers as part of it. Like in prostate cancer population, we have a 20% difference. That's that big difference. So maybe you can.
Thank you very much.
Thanks very much. That was very, very nice. I wanted to go back to an earlier question just around the time frame that you wanted to say, I'll look in this period to see if there was a re-resection done. And I, again, not being a urologist, but just imagining how tough it is to get people back to do procedures. So the issue about if you didn't want to do another cystoscopy because of the fear that you'd pick up something new on that, I was thinking if you don't think that is differential between the 2 periods of interest, meaning the rate of cystoscopy post the initial procedure, then maybe it would still be okay to broaden your period of time with which to look
longer than 2 or 3 months, or
yeah, maybe. I just worry that you're not going to pick up maybe the signal that you would hope to pick because of a system issue that you just don't have a procedural time to get it in. but maybe there was another paper published that says you should also do cystoscopy more earlier or something. I don't know about that, but if there wasn't, then it's not differential.
From the guidelines, actually. So that's not a made-up time frame. And Ken is completely correct. We'll never, I think I've gotten one patient in that time frame.
Right.
So that's why when we were talking about it, we thought we had to expand our actual window. But we thought in terms of publishing it and presenting this to the world, not everyone's in the Canadian context. So they'll say, why did you pick 8 weeks or 12 weeks? That's ridiculous. Who's going to have a resection in that time frame? So then we would be faced with the other problems. We thought this is the way to get around it.
But can you specify like a few, ahead of time, we're going to look at this, the guidelines say, but then real life, we're going to look at this frame, and you have different, so that's
Yeah, I think that's what we considered as the upper limit. Okay. Because otherwise, we have the confounding of the first follow-up cystoscopy that both groups get. So both of them get their first follow-up cystoscopy at 3 months.
Right. But I still wondered that 10 weeks was too short for the real world. But my point was around if the follow-up cystoscopy is not differentially allocated to the, resection, then is that's still going to be a problem or not a problem?
The question should go to one question would be, if you have an intervening cystoscopy between your initial resection and a re-resection, should that disallow those cases? Do you know what I mean?
Yes, that's what I would think.
But you haven't included that in your definition.
Sure,
you could say, you could do that, right? You could say 12 weeks with no at 606 between 12 and 0, like that, to help rule out exclude those cases.
It definitely improve the comparability. Thank you.
I just want to go back to the matching approach that you're taking for your cohort, and you mentioned you're using propensity matching. So there's a couple of different ways one can use propensity matching, and can you highlight your understanding of the different ways in which propensity-based approaches can be used to create this comparison cohort?
So we have the baseline characteristics of the re-resected patients compared to the non-re-resected patients will be differently. And to estimate the treatment effect, we have to make them comparable. We can either do this by standard multivariable regression modeling, or we can estimate the propensity scores of the propensity to receive re-resection based on this patient predictors. And then we get propensity scores for the patient that got re-resection and propensity score for patient that did not get re-resection. And we can use this to adjust our analysis. And we can either do this by directly weight the regression by the propensity score, or we can take the inverse of it into inverse probability weighting, or we can do a real match.
And the one you're going to do is both hard matching and matching on the propensity score directly rather than incorporating it as a weight in the model.
Yes, I just plan to do this, the hard match, to have easier way to perform subgroup and sensitivity analysis at a later stage. That's the reason behind it.
Just to carry on that point, so the rationale with propensity score approaches in general is to codify or quantify the reasoning behind the treatment by the clinician. Right? So that's the basis of it. So in an RCT, that's 0.5, and that's a one-to-one randomized design. So in this setting, but what's very important is that the information that's available to you to make that assessment has to be current at the time the intervention was undertaken, and also comparable with respect to either time frame or the opportunity for intervention in the non-treated group. And so this is a treatment that sort of is occurring over the follow-up after the diagnosis or initial resection is made, right? You're making the decision to re-resect at some point afterwards. So how are you going to account for the fact that this is something that occurs over the follow-up after resection?
Yeah, so the predictors, they have to be captured from a really narrow time frame. It makes no sense to compare a comorbidity 5 years back. So I really have to capture it close to the intervention to get a reliable estimate of the propensity scores.
And how are you going to capture the potential individuals who could be your sort of comparators in that context? When are you going to sort of assess that? So individuals who have not undergone re-resection, because you want to be able to create groups that can be compared.
Mm-hmm.
When is that going to happen? When are you going to make that assessment at the time of the initial re-resection,
Mm-hmm.
or do you have to account in some way for the fact that time has elapsed in their sort of matched counterparts?
I can go back to this one. Yeah, so this will be based on the pathology of the first diagnosis, or that's normally the date of the initial resection. This will be captured in a really narrow time frame ahead of the initial resection. And I think they are obvious how we're going to capture them. But I think what's also a difficult point is to account for time varying confounding of the surgical experience and the caseload. Since we have a 15-year-long interval, and there will be young surgeons entering the cohort and gaining experience, and there will be older surgeons that had a steady caseload. They will leave the cohort at one time when they get retired. So this will be really relevant for propensity scores. Right.
Because that layer of complexity. Anyways, I'm going to consider one term, and then I'm going to ask you one last question. So the terminology I ask you to think about is reset matching. So just keep that in mind. Reset matching. So that's something to look into afterwards. And my last question would be: you specified that there's some things that would occur after diagnosis or resection that, if it did occur, would lead to exclusion of those individuals. So can you remind me, was it cystoscopy prior to something that Ken mentioned? Something that occurs after the initial diagnosis or resection, if that occurred, then those individuals would be excluded from the study,
Mm-hmm.
right? And you'd be completely excluded from all analyses, basically.
Not for the time series, I think for time.
No. But I mean, in terms of the cohort study,
Mm-hmm.
would you exclude the person time that they contributed from the time of resection, initial resection, to when that event occurred? That would all be excluded?
Mm-hmm.
Okay, so we're going to talk about that in the lecture today.
Okay.
So any events that occur post some time origin
Mm-hmm.
that may inform, or if individuals are potentially at risk for the outcome of interest, regardless of what then that subsequently happens, you have to be very careful of making exclusions of individuals based on post-time origin events, right? Because that might in some way be systematically influenced by a tendency to be have the outcome occur or not occur, and this occurs in RCTs as well. So something we'll talk about today, maybe we can explore that a little bit further afterwards.
Perfect. Thank you.
Let's have a question. Can we go to objective 3?
Mm-hmm. This one?
So,
or this one?
yeah, so your first bullet point is causal inference on treatment effects of resection. And I just wondered, so there are different causal effects. Like you've got this far into this, but there's the average treated effect in the treated, and there's the average treatment effect. So this is two different concepts. Maybe we're going to talk about this in the course as well. But one of them is we take everybody that's at a resection, and you give them a second resection. So that's the intervention, the second resection. The other one is maybe some people wouldn't necessarily get a resection, and some do. So you're taking the people that got a resection, it's not that you're going to match them to people that didn't.
Mm-hmm.
Right? So you're not looking at the effect on the whole population, you're looking at the effect on the people who are the kind of people that get a resection. Which may not be the right question, given that there's a recommendation that everybody gets a resection. So you may be more interested in the average treatment effect overall, like everybody going from no resection to resection, no re-resection to re-resection. Because that's the recommendation, rather than, well, some people with kind of higher risk and those people might get resection. What would happen if we didn't resection those people? Which is what you're going to be getting, because you're going to be taking the people who got a re-resection and matching them to controls who didn't, and look at the difference in survival. So there's maybe think about that.
So terminology, definition.
The terminology, and also the I don't think you can answer that question about the guideline is everybody should get re-resection, but it seems that the question is about the average treatment effect overall, not the average treatment effect in the treated, which means you might need to use weighting or something to get the estimated effect rather than
marginal effect. So we're going to talk about that a little bit in the propensity score lecture as well. It's a very important part.
Thank you very much.
Any other questions from anyone in the room?
Actually, we expect any questions from the person online.
Oh, yeah. But I don't know how she will address this question.
Okay, let's see if I can
Chat window or?
If I can unmute her, maybe, and then
yeah.
switch them. try and look them up. I'm not sure what's her name.
Rico, are you here?
I am here. Hi, guys. So thank you. I was just going to make a comment about a couple of things, objective 3. I think the question about, competing risks. Can you guys hear me, actually?
Yes.
Yeah, so the question about competing risks, I think, Marian, it'll be really good if you really focus on, when to use a cost-specific model versus when to use a fine and gray approach. Fine himself talks about using both because one gives you estimate of relative rate, the other one is an estimate of relative risk. So really understanding those two would be really important for you, just so you can kind of, disentangle what it means by using some type of cost framework, but also accounting for competing risks. So I think that'll be really good for you to do.
Thank you very much.
And then for objective, objective 3, this question about, it doesn't make sense to actually match on this other cohort. So I wanted to ask, what about considering doing, the analysis on the entire cohort as an example, and then having re-resection really as a time-varying measure. And then, but at the same time, accounting for everyone's characteristics as they change over time, so you have everyone's updated profile. So what that would tell you is, what is your increased hazard of death or your outcome once somebody has obtained a re-resection compared to somebody who has not, but conditional on all characteristics at that time being similar. So what do you think about something like that? I just want to get your thoughts compared to doing a propensity score match.
It will. In an additional advantage of such a strategy will definitely be that we have a larger sample size, since we are not restricted to our match, and I might risk to lose a lot of patients that are not able to match. So this is definitely an approach that I should consider.
Yeah, I wonder if this is something you decide once you get all your numbers, and you see if matching is even going to be effective here.
I think it also really depends on the actual number of re-resection events I will capture during this time period. If I have something like, if we are doing worse than Alberta, then we have 20%, and then we have 20 other, best case, 20 other controls to match with. So I think this should also be particularly data-driven after we see the number of treated units we have.
We should probably finish the question now so we have time for discussion. So thanks very much. That was very good. Thank you. Everyone who's not IHM faculty or on the committee or an examiner must now leave the room. Discuss. Who's the supervisor?
So I'm the supervisor. I think, do you want me to discuss Marian in general or the proposal?
Like, mostly if people can give you feedback, like, that you can record and take away and kind of.
Okay. So overall, he's been excellent as a student going through in terms of the master's. He's had a desire to do a PhD. I think the project is big enough. At first, I think language was a bit of an issue, and maybe some of that came out here in terms of understanding the questions.
Finding a problem with language. I thought his English was really good. I thought he answered the questions well. There were some tough questions, which I think what happens when people think the candidate is strong.
Yeah, right. Or just a bunch of assholes. Okay, maybe I'll just make a few comments. Yeah, I got to run. I actually think this is a very interesting project. He was being presented very well, especially at the level of his graduate training at this point. And as you said, George, answered the questions quite well. And it gives me the sense that he understands both the substantive area, but he does have an appreciation for some of the methodological nuances. Clearly, there's some work to be done there, but that's part of the graduate courses and the work that he's going to do, and I think he'll come out better for it. So I actually, at a high level, would certainly be supportive of this being a PhD project. I think it's going to yield some high impact findings. It sounds like, at least from what Candy Garish is telling us. So it's a very interesting topic, for sure.
I have no major concerns. I think I agree with the audience. I think presented well. I think he has a substantive enough thesis. I don't think it's too huge, and I don't think it's too small. I think he gave reasonable answers and he's sort of willing to think and go back and so on. But at this stage of development, I have no concerns with this going forward.
Anything to add?
No, same thing. I thought he presented well. The paper fit really nice together. I think he has a story to tell, and the first two seem, to me at least, a little more easy. The third one, I'm slightly nervous with the matching and the outcomes, and I was wondering if there are any intermediate outcomes he could actually look at, given that I think the follow-up, even though it's 10 years for the first cohort, on average it's going to be 5 years, so there's not that much follow-up, I think. So that's something to consider. But yeah, good. Nice to see a thesis that is not overly big.
Yeah, it's true. We're usually too ambitious.
Usually it's
But he's also got the opportunity for tweaking, there's a lot of detail in how the analysis is going to be done, and perhaps he could even do a comparison of two different techniques and then see how they give different results and which one seems to be most believable. And especially in the time trend, right, there's lots of options for how you spin it.
Yeah,
and maybe part of that.
And the issue about how long you make the windows that become more, this issue about leaving people out, because cystoscopy in the interim is more and more important.
That was all very interesting.
Overall, I found it fairly superficial. I think largely because he's transferring really early in his training. So I think there's a lot he needs to do and probably doesn't realize how much work to do these things properly and to actually be able to defend his PhD that this is going to be. But I trust that, that will become clear to him as time.
Well, he has 4 years, right? So he has 4 years of funding.
Yeah.
So, I mean, he didn't have data to show. So, sometimes people have some data to show to transfer to 10. So that's the problem. What has he been doing the first year? Has he been doing any work on the thesis?
I think he's been going through the path stuff, right? So 80% of those path reports.
Course work too.
And he's doing the path reports himself?
So a number were abstracted before. He has about 20% to do himself.
And has he done those? Or?
No.
No. So he hasn't been doing the path report. He's been doing his courses, right? So.
Are there, on the outcomes part, I guess there's no primary data, like from a trial or something to show that should be a mortality benefit, but
that one trial.
There is one. Okay. Yeah. So I was just thinking about the range of outcomes that might be on the good side and the bad side to evaluate this whole thing, like in terms of maybe there's no mortality benefits, I don't know, but maybe there's something, but maybe there's also some downsides, and this could pick out that stuff, whether it's infections or, I don't know,
or perioperative events or things like that.
Whatever, yeah.
Detect those.
And that might be as interesting as the good, but that's true cost. We didn't even get into that, which is fine,
no financial stuff, but health costs.
I think the challenge to show mortality benefits will be all the competing risks and all the late re-resections at a practical level, which is going to all dilute away the potential effects. So, I mean, large numbers, but you may end up with a lot of noise. It'll be interesting. It'll be challenging, I think, to see a strong mortality benefit.
The hospital differences in terms of availability of cysto time.
Sure, there are.
What are they?
I don't know. I mean, it'd just be guessing, I think. But in terms of getting into re-resect, I think probably 3 months would be would be the minimum.
In
Ontario. Yeah, time to re-resect.
So my impression
8 to 12 weeks minimum.
So I guess the one important distinguishing feature, cysto is different than a TUR. A cysto is simply diagnostic. We have time every week to do that. It's not every other week. A TUR requires a GA or a spinal anesthetic, so it has to be done in the operating room. So that's what he's looking at here. So that's maybe something he should have clarified. But I find for me it's 8 to 12 weeks, like Kenneth is saying. I think in the community hospitals, my impression is it's shorter. I could be wrong.
I mean, he's looking at this as surgeon-driven. How much do you think is surgeon-driven versus institution-driven?
I think a lot of it is surgeon-driven because there are people who do not re-resect. From that point of view, a lot of it is system-driven by access and getting them in. Remember, these are older patients, right?
Clustering by surgeons.
But it's by surgeon.
I mean, then that will
there could be clustering by site too.
Yeah.
I mean, what might be interesting is to look at differences in terms of time to repeat for people who do repeat based on institution.
Sure.
I mean, there are a lot of things in terms of, I think you should go way into when people get the re-resection when they do. I mean, he's got a lot to look at there because, yeah, if it takes you 2 weeks to get your path back at your institution, how are you supposed to get people in the time period? So I think there's a deep dive that needs to go into that. Then he can use that deep dive to inform what he does next.
The problem will be, right, if you choose that 6-week window, then the headline's going to be Ontario re-resection rate 15%, right? That's going to be the headline. Okay. When in fact, the real re-resection rate is probably much higher than that.
Well, I think he needs to look at what his data look like, and figure out predictors, re-resection predictors, the timing of timely re-resection, those types of things.
All of that.
Just 2 quick methodological points maybe to bring back. Is number one, the issue of, I guess he's proposed using a logistical regression model for the second part, possibly because it makes it a little easier to deal with the clustering issue, but there is the time true piece as well, right? So the question of you might want to consider that. The other thing is, instead of using a GE, which is the marginal approach that just sort of takes care of the correlation, you might want to explore that correlation at different levels. You want more formal right effects. So true. Yeah, so that would actually then also allow you to enter covariance levels that are relevant to those clusters. Surgeon level covariates, maybe even hospital level covariates. So depending on the size of the data set. So that's something that's worthwhile. And then the other thing is,
sorry, Joe, what was that?
The issue around using the GE approach would sort of basically wash away the correlation issue, but instead exploring that really variation at the different levels using a random effect model. Right. Yeah. And then the other issue, the look back window issue that was earlier sort of discussed before 2001. So a couple ways of dealing with that possibly would be to use the actual pathology data in the early period to validate the Chi-High discharge abstract database for that interval, right? Now, it is a different period, but if it's close enough, and if there were no major, apart from, of course, the IC piece, then that gives you some sense of the reliability of Chi-High data prior to 2001. The other issue is, of course, a sensitivity analysis where you truncate the cohort itself, but then create a minimum look-back window within the time frame of when the pathology data is available. So just another way of sort of trying to deal with that issue, because it is an important process.
Why don't people do this?
Do which?
A re-resection. I mean, if only less than half do a re-resection. I mean, there's got to be a reason. People aren't,
Yeah. There's patients and patient factors, and some people just don't believe it. But if you've got an 89-year-old, because the data in support of it is not rock solid.
One RCT.
One RCT.
Not on methodologically.
Yeah, lots of
observations. So, I mean, this whole approach may be a little bit misguided then, right?
No, some people might think it's a little bit overkill for somebody with a small T1 tumor. So a small T1 tumor where you have muscle in your specimen, you're pretty sure you've got it all. Why bother re-resecting?
So that's what I think there's a lot of, maybe we can call it surgical bravado then. I'm pretty good. I don't need to re-resect. I hear that from my community colleagues. I know all that. So I think that may be there. If I have a patient, I say you need to be re-resected. I rarely, maybe a 98-year-old or a 95-year-old will say, I don't think so. But for the most part, they're willing to undergo it because it's not a big procedure.
Is it an instrument? I mean, could this be an instrumental variable analysis? Is there a possibility of looking at surgeons as instruments?
Not my field. I don't know much about that.
Kind of rando how you approach it.
But except that there's link between the surgeon and later outcomes as well, so that I don't think it's a purely neutral instrument.
This one, if they're not doing any other operation. The other thing is, are you getting the path for the second one?
Yes, that's our goal. I have no idea how that will shake out, though, in terms of capture.
Because if you do capture that, then that's going to be something very interesting to look at. So I think it's going to change completely as he really gets into it.
Totally.
Is Rinker still on?
Rinker, are you still there?
I am, yeah. You know what? I agree with a lot of Nancy's comments. I think that, he did a good job. I do think that the details he probably doesn't quite understand. So, for example, somebody had asked about competing risks and this COGS model, and he didn't quite answer that properly. But I think there's a lot of things he needs to kind of focus on, right? So the time series analysis, what propensity scores actually does, the competing risk part. And I don't even know, I think once he actually looks at the distribution of time to re-resection, I think that'll dictate everything actually, even as objective to whether he does a logistic model or not, because in his objective 2, he's basically assuming for logistic that, your follow-up time is the same for everybody, or you're defining re-resection over a very defined, window of time. So if he sees there's a lot of variation in what that means when you look at the distribution of time to re-resection, that would change what he does for objective 2. That may mean that propensity scores no longer even comes into play, and he does something that's more, something that's time to event, but then changing the actual main exposure and all the other covariates over time. So I see this being very fluid. So I don't know what's to come, I guess, but we'll only tell after we see the data, I guess.
I wouldn't be surprised if at least one of those objectives opens up in more than one chapter and this gets revised and slimmed down because some parts are growing bigger.
And that's okay.
Yeah, that's okay.
It's research. Okay, so I think we're done, unless there are other points to be made. You should write down the people who are here. Rob kind of gestured to me this.
Oh, thanks.
Where you at? The people that are not on the committee, we need to make sure we have quorum.
Because then you need to send that to IHPME.
Right.
Okay.
Been approved. Here's the
People around power. Who was the person in the back?
Lucene Abrahamina.
Yeah, if you want to spelling of her name is on her door.
Okay, everyone else I know.
A-B or...
Thank you.
Okay, so I think we're done, Riku. So thanks for phoning in, staying online.
Okay.
Okay, I'm gonna go back.
And for some reason, he wants to stay here for another 4 years.
Oh, many of our fellows who are from external want to stay. There's just no jobs.
Oh, I love Canada.
Every year.
They need people to die, do they?
Basically.
In Switzerland, not here.
I think Canada's a good place.
Oh, really?
So,
Oh, it's also the name of the place.
thank you for coming down.
Could be it. Sure. Thank you very much.
Well done.
Otherwise, we're trying to figure out why you want to be here for 40 years. Or wherever. That's very good.
We're just the weather again.
Good with period.
So, good. So basically, I need to send a report, I think, to IHME. I took a bunch of notes. I just need to know who the person in the back was. Yeah. I took the name of the person who was in the back. Abrahamian? Yeah, I was so. L-U-S-I.